Okay, the term aerosol is really talking about some sort of a particle that is suspended in a gas. Can be liquid, can be any kind of a solid material. I give the examples of a sneeze or a dust storm. Those are both examples of aerosols. We're going to use various devices to create an aerosol to facilitate the delivery of medication. It can be a nebulizer, which basically is a device that either has a small volume or a large volume. That's what the LV and SV stand for. Meter dose inhalers, dry powder inhalers, using IPPB as a mechanism to facilitate delivery. All of them work in some fashion. The goals, general goals, this is kind of like right out of Egan. Three things that we end up looking to do. One is to humidify our inspired gas, especially if the inspired gas has a concentration of oxygen associated with it. It's going to be dry coming out of the wall. We give aerosol therapy to mobilize and eliminate secretions. So those patients we talked about yesterday who had chronic bronchitis with large volumes of secretions, often they become very tenacious and need to have some liquefaction occurring with them. Going to end up having that done. And we're also primarily looking at it as a mechanism for delivery of medication, especially some pathmimetic bronchodilators and anticholinergic bronchodilators to the respiratory tract. Why the aerosol route? Why not give these drugs other way? Well, for one, it's a large surface area that's very vascular. Has a lot of vasculature. So it gets absorbed into the bloodstream, if that's what the goal is, very, very quickly. Nice part about it, especially when we're talking about respiratory medications, that's where the site of action you need to have the intervention work with. You don't have that first pass effect by going through the liver. We'll find that there are many medications that the GI tract break down due to the COMT being present. And generally there's less side effects because I'm not having to have it go through the systemic circulation in the process. Aerosol therapies, relatively convenient. Is anybody on aerosol therapy here? Takes aerosol treatments, or kids do? No. Okay. They're convenient. I mean, doesn't require a high level of function to be able to take a breath in, so it's nice. Downside to it is that there's a big variance in the amount of medications actually being administered. Especially based upon technique, you can get from very marginal to relatively decent amount of medication being actually physically delivered. So we need to make sure we're training the patients properly from the beginning, and especially when we get into talking about things like meter dose inhalers and dry powder inhalers, you'll find that the education component is drastically missing in the process. Other disadvantage of it is sometimes you need to have specialized equipment. You need to have a nebulizer to nebulize the medication. That means I have to have an electrical outlet. That means I have to clean it. That means I have to do other things with it to maintain proper function and to minimize infection transmission. All right. Let's talk about some terminology here. Of all the people who are in a hospital who know about aerosol therapy, I think we're probably the best well-vested. And I think if you, the unfortunate part is respiratory therapists don't take advantage of that. In their mind, one nebulizer fits everybody for every medication, for every purpose. It's just not the case. Okay, as we'll see. Stability talks about how long something stays in an aerosol before it falls out of an aerosol. So if you have a mist that is created, how long does it stay as a mist before it does something called raining out, which means it comes out of suspension in an aerosol and falls to the ground, okay, or falls to the tubing, or falls out of suspension, which means it's not going to be inhaled in it anymore. Penetration talks about how far down it goes. And this really is determined by a couple of different factors, one of which is how the patient's breathing, and the other one of which is the size of the aerosol particle. Smaller particles are going to go further down. Somebody who is not taking as deep of a breath is going to not have as deep of depth of penetration. Was on Facebook and was talking to reading a post from a student who graduated actually before I got into the program, but she was the president of the class before I started, so kind of knew of her and whatnot. But she's got a child who has asthma or has reactive airways somewhere along the line. Whether they've diagnosed it as asthma yet or not, I'm not entirely sure. But the child was relatively younger, and somebody posted on it, and the child was crying because they didn't want to take the treatment, and somebody else posted and said, well, my doc says when they're crying, that's better because they get more of a breath in. They get more medication in when they're crying. And I posted back, no. When you cry, most of your noise, most of the sound is on exhalation. And those inspiratory gasps you have are probably very ineffectual for delivering medication. And there's whole studies out there showing if the baby's crying, don't give him the treatment because it's worthless. We get a lot of stuff on his face, but unless you're trying to bronchodilate his teeth, I don't know how far you're going to get there. So penetration becomes very, very important when you're wanting to deliver something effectively. Deposition we talked about as far as where it's falling out. They can fall out anywhere. It can fall out back into the nebulizer without ever getting outside the nebulizer. It can fall into tubing. It can fall in the patient's mouth. Again, bronchodilating the tongue isn't going to do any good. It can fall out in the upper airways. That may be what we want. That may not be what we want. May actually get to the point where the particle size is small enough that it actually gets deposited down into the alveolar surface, or the general idea. This is just out of Egan, looking at the size of the particle and how rapidly it stays in suspension. Bigger particles obviously are going to fall out earlier than smaller particles. Then there's the process of inertial impaction. So as this aerosol is flowing through the airways, there's a requirement for it to take a whole lot of turns because there's bifurcation of those airways at different points along the line. And that's really where most of the inertial impact happens, is when that airway divides. If you take a look at a lot of bronchogenic carcinoma that the cancer is caused secondary to cigarette smoke, or cigarette smoking, part of the problem is those typically occur at a bifurcation of an airway. So as the lobar bronchi are splitting into segmental bronchi or segmental into subsegmental, that point of impact is where the smoke particles and the tar and nicotine and everything else impact, and that's where you typically have a lot of cancerous tumors forming. Right there. Inertial impact. So, there's lots of different ways that we can quantify how much aerosol is being delivered. The one that we're going to focus on is something called MMAD. Okay? But there's other ways as far as you can say so many milliliters per minute is being utilized. But this mass median aerodynamic diameter is talking about how big the particle size is. And most of the devices we'll use are somewhere between 1 and 10 microns in size. Are you bored yet? I would be. Okay. Particle size dictates where it ends up. If the goal of my therapy is to deliver medication to the laryngeal structures, that's a whole different style of aerosol generator I need than if I need to get to the smaller bronchioles, which is totally different if I want to go to the alveolus. Okay? If I'm delivering an antibiotic, I don't want it to go to the airways. I want it to get down to the alveolus because that's where the site of infection is. If I want to give a bronchodilator, stimulate the adrenergic receptors that are inside the smooth muscle or that affect the smooth muscle in the airways, that's a different particle size. Okay? And different devices have different characteristics. So one aerosol generator will generate aerosol particles that are of a size that will impact in the upper airway. Some will be in different ones. Some will be different for alveolus. Okay? One size does not fit all, and that's part of the problem with our application in the clinical sense. We kind of use one for everything, and it's like, no, can't do that. But that mass median aerodynamic diameter, MMAD, is talking about what is the median diameter of a particle. What is at the 50 percentile range? And just as a way of expressing how big the particle range of sizes are. Okay. Here's the different diameters that we're talking about. And you can see tobacco smoke, viruses, they're damn small. In fact, to the point where tobacco smoke not only goes in, it's so small of a particle that it stays in suspension and comes back out again, still as a particulate aerosol. Okay? While other things, like some dusts and our medicated aerosols, are in a much bigger range. And if you'll notice, they have higher deposition in the tracheobronchial tree. And to some extent in the pulmonary system, which is ideally where we want to have. So if we want to have something affecting the airways, we want it to be in that 1 to 10 micron range. Make sense? Okay. All right. So there's many of those things that are going to affect how much deposition you end up having. We talked about inertial impact. We talked about just simply gravity. Okay, bigger particles eventually will fall out of motion. There's something called Brownian collisions, where just random movement, they're going to collide with each other and knock themselves out of particles. And there's another factor in there that as we go from a cooler environment to a warmer environment, as we go from a dry environment to a more humid environment, the particle actually changes. And you can actually see the size of that particle change as we go from outside to inside. In fact, the particles can actually get larger, they coalesce together, and they fall out. It's called aging. If we were to have really big stuff above 10 or even above 100 microns, 100 microns doesn't even get into the respiratory tract, it just gets impacted in the mouth. Or in the nose if you're breathing through your nose. We want to get that particle size somewhere in the middle of that 1 to 10 range, because we know if it gets too small, it doesn't even get to be deposited necessarily. It can be exhaled back out again. A typical aerosol delivery, only 10 to 20% of the drug is actually deposited into the lung. That's lousy. So we give somebody a breathing treatment and only get 10 to 20% of the drug. But even despite that, it's still okay. Some of it goes into the oral airway and the stomach, which is one of the reasons why, especially in a crying kid, it's going to impact in the back of their throat. They're going to swallow it, and then they're going to throw up about 2 minutes after the treatment's done. Okay. A lot of it's lost in the apparatus, the tubing, the mask, the mouthpiece, the nebulizer itself. And because a nebulizer typically is a continuously generating aerosol, some of it's generating during exhalation, which is a total waste. Okay, so it's a loss of the environment. Yeah? Well, the dosages which are the recommended dosages are the ones that have demonstrated efficacy and ability to improve bronchodilation in the case of a bronchodilator, despite the fact that we're only giving a small amount. Now, if I had a more efficient nebulizer, I could get by with less drug in a shorter duration of time. And there is that out there. but it costs more money for that kind of a nebulizer. So it's a trade-off. Do I want to have my respiratory therapist do a treatment for 10 minutes, or do I want to have my respiratory therapist do a treatment for 2 minutes? Well, if I do it for 2 minutes, I can do a whole lot more treatments, and the bottom line is you may actually save money in the long run. Well, remember Medicare, at least in the hospital, they don't care how you administer that therapy. You're getting a flat fee. Okay? Pardon me? No. No, not necessarily. And when we get to the frequency of therapy, we'll talk a little bit more about that, because it's kind of a sad testimonial as far as historically what has happened there too. This is looking at a dry powder inhaler, a meter dose inhaler, and an meter dose inhaler with something called a holding chamber, and just a small volume nebulizer. And this orange here is the portion that is deposited into the lungs. And you can see actually a dry powder inhaler is probably your best bet as far as administration. The nebulizer is not that great, and the MDI is even worse. But when you get something where the MDI is used with something called a holding chamber, you actually can get some pretty good amount being delivered. A lot of oral pharyngeal deposition. It's minimized with those two, and basically, as a trade-off, you make that the medications deposited in the holding chamber.
An actual powder.
Dry powder inhaler? Yeah.
I mean, wouldn't that be hard to do, like inhale powder?
No. No. No, it's such a fine particle that it's not something that causes the same thing as if you were inhaling dust, you know, where would promote a cough.
Well, like some people like try smoking for the first time and they just start coughing.
That's good. They should cough all the time.
Can you get the same effect? Will it stimulate that cough?
Yeah. Now that's a meter dose inhaler you have there. That's a little bit different than a dry powder. We'll talk about them as we go through, but some medications are not available as a DPI, and we'll talk about advantages and disadvantages of each of them. Hold your horses. All right, so things that we need to consider, and this is basically based upon some aspects of their technique. DPIs specifically have to have a certain amount of minimum inspiratory flow to be able to be used. If the patient can't generate a certain inspiratory flow rate because their respiratory muscles are too weak, because they're a child and can't generate that flow rate, DPIs are not indicated. You have to have a certain flow rate, may be a factor involved. How the patient breathes is very, very important for the delivery of medication. Their respiratory rate, their flow pattern, their ability to take a deep breath, their ability to hold their breath. Because remember what ends up happening as you take a deep breath in of an aerosol and you hold it, you allow for gravity to affect that sedimentation and to fall out. Because I'm just holding that gas inside of my lungs. Give you better deposition. Breathing through their mouth as opposed to their nose. Remember those vibrissae that you have up there? They kind of like defeat the purpose of having aerosols go in because they're all trapped inside your nose. Okay. What are we using? Are we using a mask? Are we using a mouthpiece? Is the patient able to follow directions? If they're comatose, how effective is that therapy? Different drugs have different characteristics. They stay in suspension longer. Some of them don't stay in suspension as long, so you got to take that into account. Which patient are we using? Here's this looking at some deposition. Let's see, what is this showing me here? Each have a tidal volume and a respiratory rate the same, and we're looking at a particle size of about 1 micron. Normally you have a deposition of about 15%, and you can see that that changes as you have different disease states, because they have different breathing patterns involved. It's just kind of showing the same kind of thing. Different particle size, bigger particle size, bigger Smaller particle size, better deposition. Lots of aerosolized drugs we're going to focus with. We don't do too much with nasal decongestants, but that is, obviously, they're the drugs that you might take to relieve your allergy symptoms. We're going to deal with primarily bronchodilators, mast cell stabilizers, corticosteroids, mucolytics, antimicrobials. Those are primarily ones that we aerosolize to be delivered. So how do you choose which one? Well, it depends on all of these factors. Do I want something that needs to be done rapidly? Well, that's going to dictate something where I'm going to want to use perhaps one device over another. Cost. Some devices cost more. An MDI with a spacer or an MDI with a holding chamber is far more optimal than just an MDI by itself, but it also raises the cost of the patient. Availability. Some drugs are not available in multiple forms. It's only available one way. Yeah.
Something happened with inhalers.
Yes, we'll talk about it in a second. Hold that thought. You're way ahead of me, guy. Patient type, we talked about pediatric. If I'm delivering to a baby versus delivering to a child versus delivering to an adolescent, an adult, an old person, that all has to be taken into account. Ease of use. Is it easy to train? Okay. Can I teach a 5-year-old to use an MDI effectively? Yeah. Location of use. If I have a device which requires power, kind of makes it impractical when you're, when you're at a picnic and you don't have that necessarily available, unless you have something where you can use the car battery involved. And there is a clinical practice guideline. I know you never heard of these before, but the ARC has come out with a kind of a guideline to give you an idea of what kind of device to select. And there's all those factors, how they might play into the process. Different considerations. Mechanical ventilation. What about if I got to give a drug through an endotracheal tube on a patient who's intubated? Well, there's different things you got to take into account there. Simple to administer. Practitioner safety. Is the medication I'm administering something where potentially it could affect us? Antibiotics are a classic example. You really don't want to have antibiotics, especially some antibiotics or some anti-whatever agents, released to the atmosphere. Because there can be problems with you. If you're, if the caregiver's pregnant, you don't want to have some of those medications available. Bizarre drugs sometimes require specialized aerosol devices. Love this. Dexterity of patient. Well, because gymnasts have asthma too. Did I ever tell you that story? I was, Nancy Hogshead, did we talk about her? She was an Olympic swimmer, won 3 gold medals, was going for her 4th, I think it was her 4th, and it was the relay, and she was the last leg of the relay, and she ended up coming up short, and turned out she had asthma. And the weird part was her father was a physician and was never she was never diagnosed. But she was at one of our seminars one year, and she brought her gold medal. Did you ever hold a gold medal before? That is so cool. She passed it around to us. It's like, man, you are crazy. Contamination's an issue as far as having, especially in the home. Think about a patient who has breathing therapy, has a nebulizer in the home. They got to clean that. If you don't clean it, you basically have a reservoir now for nebulizing guck. That's not a good thing. Cost involved, need for electricity or power of some sort, age of the patient, the different disease states, it's going to affect their ventilatory pattern, the severity of the disease. Propellants I'll talk about in a sec, whether or not it's something compact I can carry, whether it's something that's multi-dose. All those factors need to be taken into account. And of course, Egan has this wonderful algorithm. Notice what it says though. If you have an MDI or a DPI, that's probably your best route to go. We're going to find those are your most advantageous that you can have. If not, then you might have to look at some other type of nebulization involved to be able to deliver the medication. So let's talk about a couple of them. Small volume nebulizers, good news about them is that you really don't have to follow directions. Now, saying that means that I can use a small volume nebulizer to deliver an aerosolized medication to a patient who's comatose. How effective that is, that's up for debate. Because really, in order to take an effective treatment, you have to, as we'll find, have a breathing pattern that promotes a deep breath with a breath hold. Well, if I'm comatose, I can't follow those directions very effectively. But, yeah, I can slap a mask on somebody's face, and in theory, some of it's going to get down there. Somebody who has a very unstable ventilatory pattern, again, the same kind of thing where they're not able to follow directions, can't hold their breath, can be given. Yeah. Sometimes drugs aren't available in other forms, so I'm kind of locked into using a nebulizer to be able to deliver it. And some patients like it. MDIs, if they can follow directions and can demonstrate correct use, and we'll find that's the most important component, that they have a good inspiratory capacity, the ability to take a deep breath and hold their breath. And sometimes the drugs are only available as an MDI, so you don't have an option to look for something else. Hello. Spacers are something we're going to find, and holding chambers are something which facilitate delivery of a meter dose inhaler in those patients that don't have coordination. I'm going to try to have a patient use an MDI who's 82 with rheumatoid arthritis. Oh, there's a fun time. Okay? So using a holding chamber helps out a whole lot more. Use of an inhaler that contains a corticosteroid almost necessitates the need for having a holding chamber or a spacer, because the incidence of oral fungal infections is quite high, especially in kids where they don't follow directions as far as rinsing out their mouth because of that oral pharyngeal deposition. DPIs are good, especially in uncoordinated people, because they don't have to coordinate anything. They just got to take a breath in. There's some issue with propellants, although you can also say there's some issue with the dry powder patients have. But you got to have a high flow rate. That's probably the most important component. There's a meter dose inhaler with a holding chamber, or this is not a spacer, but a holding chamber, but we'll find out the difference as we go. And here I have the same thing with a child with a mask. So I've had physicians tell me that a 3-year-old can't take an MDI. Yeah, they can. 6 months old, they take an MDI. Obviously, somebody else has got to do the coordination with the baby, but using a holding chamber, you can get through multiple breaths the effective dose being administered. That meter dose inhaler is the most common medication delivery method. The canister itself has multiple things inside of it. Beside the drug, which is in suspension, there's usually some sort of surfactants or co-solvents, often are ethanol-based. We used to use, as we'll see in a couple of slides, CFCs. We now use HFAs, hydrofluoroalkanes, as a propellant mechanism. And then there's some preservatives and flavoring agents that are there. 28 to 63% of patients do not use an MDI well enough to benefit from therapy. That's a lot. Since there's about 500 million MDIs, that's about $25 billion. You want to reduce your healthcare costs, folks? Let's train people how to use MDIs appropriately. This is amazing. They did studies looking at healthcare workers, physicians, nurses, pharmacists, therapists. A third to two-thirds of them did not know how to adequately tell a patient how to do an MDI. It's no wonder that half the patients can't effectively use them. Okay. Give you, for instance, one of the, well, let's just say a past student who took this course, came up to me after class and said, you know, my doc's got me on MDIs. They don't work. I said, oh, okay. said, well, talk to me after about 2 lectures when we go through how to properly use an MDI. And he came back and he said, I've been doing it wrong. I said, well, it's probably why it doesn't work. If you don't do it right, you're not going to benefit out of it. And we'll find that one of the key parts about meter dose inhalers is having the patient do a return demonstration to you. And one of the things we have here are a bunch of placebos, so you can practice without actually having the multiple drugs being administered. Majority of the spray is the propellant, with only a small amount of the actual spray, the mist that is created, being actual drug. We'll talk about the different design as far as what the different components of it is, metering chamber, and a valve stem, and an actuator orifice. But most of the drug, especially based upon the technique that is used, is impacted on the oropharynx. So basically you're spraying the uvula with a bronchodilator. Not an effective mechanism to end up using it. Good particle size, that's not the problem. The problem is the speed at which the gas is coming out, or the aerosol is coming out. It's coming out at such a rapid rate that, depending upon technique, it's very easy to impact the back of the throat. Okay. So as we'll kind of go through these, but you can see here's the drug inside this canister. The canister has an actuator that basically is this outer shell, and what ends up happening is I push down on that, the actuator and the metering valve come in contact with each other, and the drug is dispensed out the actuator nozzle. Okay, and that's basically how the aerosol is created. Now, there are going to be problems with every bit of that process. As we'll find, this mixture needs to be mixed as part of the application process. The actuator nozzle has to be open. If it's clogged because of old drug that's dried there, you're not going to have an effective mist being created. Chlorofluorocarbons were propellants that were used that are pretty much being eliminated. Not quite yet. There still are some drugs on the market that have them. But because of the danger to the ozone layer and global warming and aerosols were causing this problem, they were replaced by hydrofluoroalkanes and dry powder inhalers. The problem is that a manufacturer who had a medication that had CFCs as their propellant now have to go back through all the drug testing process to verify that using an HFA has as effective of a drug as I had before. That's awful damn costly. And a lot of manufacturers said, screw it. It's not worth my while. Okay? So that's why some of those have been pulled off the market. Again, the CFCs have been eliminated, or are in the process of being eliminated. There's still a handful of them out there who utilize it, drugs that we would administer. You can believe what you want, or I'm saying believe what you want, but yeah, okay. There you go. I don't care about it. Ozone, oh my God, it's so terrible. Yeah, whatever. So the conversion happened that all of a sudden we went to HFAs versus CFCs. So patients who were taking this medication and were told now you're going to use this medication, all of a sudden said, I don't feel it. This medication isn't working. And part of it had to do with what's called the plume, the size of the mist that is created. The HFA created a much smaller mist, which actually is a better thing. Because if I put my mouth somewhere proximal to this majority of it's going to hit the back of the throat. With this device, more of the medication actually is inhaled. And when we talk about technique as far as how to teach a patient to do an meter dose inhaler, that fact becomes very important. But it took a lot of convincing of a lot of people to tell patients that no, your new Pro Air inhaler is as effective as your Proventil was. It just is a little bit of different design as far as how it's delivered. Trust me. Which they never do. We know the advantages of an MDI. It's portable, it's compact, easy to deliver the drug. Treatment time in the hospital is pretty easy. You're in, you're out, couple of minutes. Whole lot easier. Some of the disadvantages, and the biggest disadvantage, is hand-breathing coordination. Can you walk and chew gum? You'll probably do okay. Talking about a patient who perhaps has some learning disability, somebody who's aged, somebody who has, like I said, arthritis, whole different story. Other disadvantages, drug concentration's fixed. I can't increase or decrease the amount of dose like I can with some other delivery mechanisms. Canister depletion is difficult to tell. As you actuate that medication, obviously it's going to eventually get empty. Problem is that as you're actuating it, you can still see a plume of mist coming out, but as it gets lower and lower, remember only 1% of that is drug, you actually get less and less medication. You'll have the propellant and the other stabilizers, but you don't have drug anymore. We used to teach. Well, never mind. I'll talk about that as we go along. Some patients have a reaction to the propellant or to the actual impaction that is there. Foreign body aspirate. You know, mom's got her inhaler in the purse. She throws her change in the purse. A dime gets caught inside the actuator orifice. She doesn't look. It's happened. And we'll stop there.